Welcome everyone to COVID-19 Provider Update number 94. I'm Dr. David Battinelli, Physician in Chief here at Northwell Health. And before we get started, just our typical housekeeping details. Remember, you can obtain CME credits. Just need to fill out a couple of things. And we don't have anything to disclose today, so great. All right, so today we're going to have our typical COVID-19 update, including flu and other things of note by Dr. Bruce Farber, our Chief Public Health and Epidemiology Officer. And then we got a couple of special presentations, some new CDC guidelines for prescribing opioids by Dr. Yili Wang, who's our Western Region Director for Pain Management Services, and then joined by Dr. Nancy Barron, who's our Chief Quality Officer for the ambulatory operation about co-prescribing naloxone. Panel discussion, quick book, and Dr. Farber, I guess it never ends, but tell us what we need to know today.
Thank you, David. It does never end. And unfortunately, we're seeing the price we paid for that great Thanksgiving we had several weeks ago. And there is a new COVID wave. As you see, the numbers have jumped almost 25% with hospitalizations. And this is the United States data. ICU numbers are also up about 12%, and wastewater surveillance levels have increased too, which demonstrates that this will probably go on for at least several weeks. Next slide, please. And as you can see, the daily U.S. hospitalizations by age are different than the other hospitalizations. And what you notice from this slide, which is not surprising, but is the significant change based on age in hospitalizations. And I wouldn't say exclusively, but the overwhelming majority of the increase is related to people 70 and over. Next slide, please. And you can also see that the numbers in nursing home recipients have also climbed, obviously going along with the aging population, but also a factor that the overwhelming majority of people in nursing homes still have not gotten at least one booster. I'm not even talking about the bivalent booster. I'm talking about one single booster. And this is responsible also for the increase in the rates in nursing homes. This is the worst rate we have seen in nursing homes since February. If you will recall, February was when we were the height of the Omicron epidemic. And so the rates are really pretty high and went up a lot faster than I think everyone predicted. Next slide. This looks at daily admissions by age in California, and I just want to show you how consistent this is. Look at 70 and up, and look at that dramatic rise in hospitalizations over the past 3 weeks. It's really quite impressive. Next slide, please. And this looks at New York and California, and what you can see on this slide, just to show you how high the rates have climbed in just the last 2 or 3 weeks, that our current rates for seniors now exceeds the Delta wave, the B5 wave, as well as the BA2 wave. So we're really in another wave, I think is fair to say, and particularly since we're significantly higher than the Delta wave when it comes to people over the age of 70. Next slide, please. This looks at the same time frame, September to now, and look at the booster uptake in England among 65-year-olds compared to the United States. And you see why we are not doing as well as we should. In England, a country very comparable to ours, 77% of people over the age of 65 have gotten at least one booster. And again, I'm not talking about this new bivalent booster. I'm talking about any booster. And that's only 34% in the United States. And that alone is a very good explanation for why we're seeing our rates so much higher than than rates in Western Europe, where the standard of living is actually very similar to ours. Next slide. This looks at flu. I'm going to change directions for a second, and there's no stopping flu. Laboratory tests are extremely high. Our positivity rate is the highest it's been in the history of the labs, and it keeps growing. It's a 64% increase over the week before, I'm sorry. And there were a 58% increase in laboratory confirmed cases of flu over the last week, including one pediatric death in New York. About 2,000 deaths so far in the United States due to flu, and we're very early in the season. Next slide, please. This looks at an interesting thing, which shows that almost 7.2% of all people going to a doctor currently are going for some type of respiratory infection. That's up compared to what it normally is of 2.5. So it just gives you the magnitude of how common these respiratory viruses are, which you know, RSV, flu, and COVID are circulating. Next slide, please. This is New York State flu. And again, this slide, I think, demonstrates everything. If you look at the past 3 years on the lower part of the slide, and then you look at the red, that line going straight up. Number one, we've started very early. At this time last year, there was no flu even in the community, and we're almost a logarithm above where we were last year at the height of the flu epidemic. And this is affecting all age groups, particularly young children, as you can see, but also adolescents and elderly people. So no one gets spared from this disease. Next slide. This looks at the 2022 flu season, which we're in now. And you can see that we're in for probably the worst flu season that we will see in the last 13 years. Next slide. And this is finally my last slide on flu. This is Northwell's data. And you can see the positivity rate at Northwell with flu, which is in red, is the trajectory continues to go up. The good news is that RSV, which is in yellow, is definitely going down. There's still a lot of cases in Cohen's Children's Hospital, but there's much less. When you look at COVID, it's rock steady. It's up a little bit, but it's pretty steady. And finally, when you look at rhinoviruses, you can see they're significantly down. And September is always the peak month for rhinoviruses because kids return to school. Now, next slide. So in summary, this is the worst flu season we've seen. Our vaccination rates are very poor. Only 40% of children have been vaccinated, and only 26% of the American population has been vaccinated against flu. So, you know, I really remind people to just twist your arm of your patients. This is sort of their last chance before at least the Christmas and New Year's holidays to get vaccinated, and it does make a significant difference. And as you know, there's new guidelines to put your mask back on. I don't think many people are following those guidelines, but they are making those guidelines because of the incredible increase in the rates that you see. And please, if you're sick, don't come to work. Next slide. So the last part of my slide talk, and I'm going to go through this very quickly, but I couldn't help but bring this up. It's all over the news. The data that I'm going to show you mostly comes from The Economist and from Nature, and now it's all over the media. But I just think you need to just see it if you haven't in 3 minutes. So this is the proverbial "you painted yourself in the corner" slide, and I think you probably all know what I'm referring to, but let's go to the next slide. And this is what China's lockdown policy looked like. And please, next slide. It was truly draconian. I mean, people in hazmat suits, locking people into their buildings. You couldn't get on a subway. You couldn't go into an outdoor park without proof of a negative PCR done that day. Next slide, please. And how was it handled? So in summary, you know, China has about 1.4 billion people. They relied on brutal lockdowns and massive repeated PCR testing, usually twice a week. It ultimately led to social unrest, which has led them to back off. Now, vaccine uptake in China has not been high, and for the most part, they've used 2 vaccines, the CoronaVac and the Sinopharm. Both of these are killed vaccines that have rather poor efficacy unless you get 3 doses. Their efficacy is still not great with 3 doses, but it's adequate to prevent most people from dying. Pfizer was used in Hong Kong, but almost no Pfizer was used in mainland China, with the exception of probably some of the very elite. Next slide. And how was it handled? Well, you know, the lockdowns caused a 45% decrease in domestic air travel. no international travel, a 14-day quarantine if you are going to come into China for any purpose, 18% unemployment rate in the country, which has enormous economic growth, and PCRs were done twice a week. Now, what's going to happen now that they have backed off on their restrictions? And you see it literally happening much faster than anyone even anticipated. They predict that there will be at least 45 million infections every day as the instructions are removed. The first large wave could cause 840 million infections out of 1.4 billion people. And there is a shortage of Paxlovid, which they have not stockpiled. And although they claim to be able to build hospital beds, their hospital beds are isolation wards and not hospital beds that you can take care of patients in. They're really dormitories. Next slide. So what are the consequences? They are seeing a wave of BF7, which we have not seen in this country, but it is another B variant, not that different. The predictions are that there will be somewhere between 160 and 280 million deaths, even with the less virulent Omicron. And ICU demands will be at 15 times the current capacity. Vaccine coverage is getting better in a massive campaign, but is not high enough to prevent this epidemic. Next slide. I'll finish up. And just to show you the numbers that came from Nature that aren't in the newspapers, these are the models that predict 1,700,000 deaths and about 225 million cases as a conservative estimate. It's a mind-boggling number based on what happened. If you compare that to other countries, India had roughly 530 deaths, and of course, the United States took the gold with 1.1 million total deaths. Next slide. So what are the consequences? They need to rapidly get their elderly people that third shot. And the real problem they have, and that's why they painted themselves in the corner, is the elderly people don't want the shot because they've always preached that shots aren't particularly good. And so they've sort of in a very difficult pivot situation. Next slide. The vaccine effectiveness, which was studied in Hong Kong, showed that both Pfizer and CoronaVac vaccines were available in Hong Kong, but vaccine coverage has been low, particularly in those over the age of 70. And although the vaccine worked to prevent death only when given in 3 doses, and only 20% of their elderly population has gotten 3 doses. Next slide. So I will finish with this slide. The conclusions were that 3 doses are needed. A reduction in vaccine effectiveness was observed with the 2-dose regimen, in this controlled study, particularly in those over the age of 80. The high death rate observed in Hong Kong is at least partially related to the older population that largely remains unvaccinated and infectious naive. Thank you, David. I'll turn it back over to you.
Thanks, Bruce. Sobering issues, and we'll certainly tackle some during our panel discussion. So at this point, I'm going to turn this over to Dr. Yili Wang, who's going to tell us about some new guidelines for prescribing opioids. Obviously, a complicated, to say the least, clinical area. So Yili, thanks for being here, and tell us what we need to know.
Thank you, Dr. Battinelli, Dr. Farber, and team for the opportunity to discuss and present on this important topic. I hope to give a sense of where pain care is today. And I'm privileged to represent our amazing colleagues in quality, the Opioid Management Steering Committee and Pain Management Services to help give an idea of how Northwell is uniquely prepared to provide high quality pain care. I'd like to start this discussion with a focus on empathy. Chronic pain is a truly debilitating condition that affects every aspect of daily lives. Our patients are often stuck in a debilitating vicious cycle, and it's crucial for us to be compassionate about it so that we can be effective care providers. Chronic pain is also ubiquitous. It affects more Americans than many of our other chronic conditions that we treat. Unfortunately, as you know, one of the most efficacious pain medications that we have, opiates, have contributed to drug overdoses, which has become one of the leading causes of mortality of young Americans. And that number tragically continues to climb to over 90,000 American lives in 2020. To that point, our opiate epidemic may really be rooted in a crisis of pain management. Therefore, as you all are likely aware, in 2016, the CDC released opiate prescribing guidelines, which, as you can see here, was very, very successful in its intended effect of curbing opiate prescribing as a whole. At the same time, Northwell formed the Opiate Management Steering Committee, which engaged stakeholders across our system to work to adapt to the dynamic environment around our opiate crisis. So across the country, however, although these prescribing guidelines did effectively curb opiate prescribing, it also led to less desirable effects for many patients. Specifically, patients on chronic opiates were turned away from offices and often abandoned, likely because of fear of liability, barriers that are put up by payers and pharmacies, and associated stigma. Now, stigma not just for the patient, but also for the prescribers. In fact, a secret shopper survey where the authors called primary care clinics claiming to be new patients on chronic opiates found that 43% of the clinics wouldn't even take them on. Another significant issue was overzealous opiate deprescribing. Clinicians often drastically decrease or discontinue opiates too quickly for patients who've been on it for years, which led to withdrawal and other dangerous consequences for these patients. That actually led to the Department of Health and Human Services to release a likely emergent guide on appropriate weaning in 2019. So where are we today? Just in November, the CDC updated its opioid prescribing guidelines. This was absolutely necessary because, as the update states, misapplication of the previous iteration has contributed to patient harm. This specific update attempts to rectify this by stressing the importance of flexibility and individualized patient-centered care. I'd like to take some time to go over what's new here and the specific guidelines themselves. The key concepts center around a few things. They center around clarifying who this is for. This is for outpatient adults with pain. And who this is not for. This is not for pain associated with sickle cell disease, cancer, or palliative care. The guidelines are not meant to be algorithmic. They're instead meant to be individualized and collaborative between the clinician and the patient. These guidelines also specifically take time to describe appropriate weaning, which is often about 10% reduction per month, but can again vary by patient and case. Additionally, these guidelines make an effort to provide some basic pain education, which is great. And it specifically defines what acute, subacute, chronic pain is, as well as details some of the effective non-opiate, non-pharmacologic pain treatments. Finally, the CDC emphasized that these guidelines are just that. They're guidelines. They're not meant for payers or regulators to set standards. Now, as it pertains to the actual steps of opiate prescribing, the CDC breaks it into 4 broad categories. First, should we even initiate opiates? Oftentimes, opiates are not necessary to treat pain, and non-pharmacologic and non-opiate therapies should be optimized. What's key here is function. It's not just the pain score, and the function should be the guide to any pain treatment. And just like all treatments that we give, there must be a balance of risks and benefits. And both the patient and the clinician's responsibilities should be discussed and understood. Second, when we decide to initiate opiates, how do we do it? It's essential to always start with immediate acting opiates because initiation of long-acting formulations in opiate-naive patients lead to fatal overdoses. It's also key to prescribe the lowest effective opiate dose. A specific dose limit has been de-emphasized in this update, but we should keep in mind that the evidence does suggest that over 90 morphine milliequivalents that leads to significant increased risk of fatal overdoses without increased pain relief. The third thing is how long should we prescribe for, and what do we do when we are prescribing? Generally, for acute pain, we should prescribe no more than needed for the duration of the pain. Again, in this update, the time frame is de-emphasized, but we should keep in mind that the evidence does suggest that most of the time, that time frame is about 3 to 7 days. And during treatment, it's essential that we regularly reassess and taper if pain and function does pain relief and function do not outweigh the risks of opiate therapy. The last thing is, how do we assess opiate-related risks and how to respond to these risks? We can start the assessment by checking the prescription drug monitoring programs such as iStop with every prescription. And we can perform random urine drug screens to ensure patient adherence and compliance. We must be cautious that concurrent benzodiazepines and other sedatives may contribute to synergistic respiratory depression with opiates, but the recommendation this time around is less stringent than that of 2016 because we understand that sometimes concurrent use cannot be avoided completely. And we must be mindful of harm reduction and offer naloxone to those at high risk of overdose, as Dr. Barron will expand on. We must also be aware of the diagnosis of opiate use disorder and understand that there are available treatments for that. And these treatments are available from our Northwell Addiction Services team. Now, this document is very long, but I think it's very well thought out. It's educational, it's rational, and I encourage everyone to take a look at it. Now, beyond just the CDC update, the back and forth of the pendulum opiate prescribing swing have left a stigma for our patients and even our clinicians who treat patients in pain. The key thing to know here is that we are not alone. Thanks to the incredible and timely efforts of the Opiate Management Steering Committee through the years, we at Northwell are uniquely positioned to continue to strike a great balance between compassionate pain care and judicious prescribing. And I'd like to share some resources with you. These resources start with education. We have multiple non-synchronous CME offerings available for all team members to take at your own pace. Our pain care education series discusses evidence-based and multidisciplinary modalities of pain treatment. Additionally, we offer an education series that promotes awareness, benefits, legalities, and the realities of medicinal cannabis. It's vital for us to have appropriate tools. One specific tool is the Opiate Management Care Plan. This is a one-page note form that walks the clinician through step-by-step on how to assess the necessity, efficacy, and risks of chronic opiate treatment. This note form is available in TouchWorks, but can be made available and adapted to additional EMRs as well. Another available tool is a guide to understand what opiate dosing and daily morphine equivalents look like in real-world prescribing. Again, opiate dosing itself alone should not be taken as an isolated value, but instead be part of a larger picture of opiate-related risk. There are also patient-facing tools that are available. We have a patient-facing document to help our patients better understand their pain, and a controlled substance agreement to help our clinicians outline prescribing policies, obtain informed consent, and mitigate the risks of opiate prescribing. We understand our clinicians may have patients whose pain, regardless if they are using opiates or not, remain difficult to manage and are beyond their normal skill set. We're proud to introduce the Northwell Telepain Care Center. The mission is to leverage telehealth to provide innovative, timely ambulatory pain consultation and treatment services. Think of it as an easy button for referring clinicians to help their patients navigate care to consultation with pain management specialists within 72 hours. Although through the telehealth visit alone, the patient may not be able to receive controlled substances such as opiates, establishing care with the pain specialist early often helps patients find innovative diagnostic and opiate-free treatment options. And the consultative warm handoff from our pain specialist back to the referring clinician optimizes care and mitigates risk. We probably cared for over 300 patients across the system over the last couple of years. The take-home message here is to balance compassionate pain care with judicious prescribing. What we need to remember is that pain can often be treated with non-opiate therapies. But in cases of severe, intractable pain, opiates are indeed necessary. When we do utilize opiates, however, we must be thoughtful and purposeful in order to minimize risks to the patient and our community. Unfortunately, at Northwell, we are uniquely positioned to have the resources to help us continue to strike this balance between compassionate care, pain care, and judicious prescribing. Thank you so much for all that you do.
Thanks, Yuli. So now let's look at the complementary necessary skill set, and Dr. Nancy Barron is going to walk us through that.
Thank you, Dr. Bandinelli, and thank you, Dr. Wong, for setting this up. I wanted to highlight what we are doing in ambulatory to be better stewards for opioids. We have set up about a year ago the Ambulatory Opioid Stewardship Council. It is a work stream of the System Opioid Task Force that Dr. Wong was referring to. And our goal is really to raise awareness in the ambulatory environment to all of the resources that were mentioned that Northwell's developed for pain management, as well as to really help our providers learn and judiciously prescribe opioids. We developed a multidisciplinary team where we are sharing the resources and identifying where we need new resources. We're educating on pain management and helping to create referral pathways to the already existing wonderful programs. We've created a dashboard that really allows us to identify opportunities for improvement. We're educating on naloxone co-prescribing, which I'll be talking about more, and we're going to be implementing strategies to drive down opioid-related overdoses. So just like to take a moment and just review the risk factors for opioid overdose. The highest risks occur in individuals with opioid use disorder, those individuals who have had a period of abstinence, perhaps coming out of rehab, which leads to a change in tolerance, those with comorbid medical conditions or co-occurring mental health disorders, the use of opioids with other substances, benzodiazepines, Ambiens, alcohol, street drugs, certainly concerned about drugs that might be laced with fentanyl on the street, those that are prescribed higher doses of opioids, patients or individuals with a history of a previous non-fatal overdose, and just using opioids alone. So in response to this, earlier this year, New York State passed Senate Bill S2966A, and we sent out some communication, but we felt that it was really important to take the time to highlight this particular legislation. This legislation requires co-prescribing of naloxone for all patients with high-risk opioid prescriptions when prescribed in an ambulatory setting or upon discharge. So think about it. Anyone who's going out into the ambulatory environment, sent out of an ED, a hospital, or prescribed in the office, needs a co-prescription for naloxone in any of the following three situations. They have a current or history of substance use disorder. They're receiving a high-dose prescription that is greater than or equal to 90 MME. So that graph that Dr. Wong shared with the red, yellow, green can help you quickly tell whether or not you're prescribing in that range. Or patients who are given opioid prescriptions regardless of the dose that they are given if they are concurrently on benzodiazepines or non-benzodiazepine sedative hypnotics. So you're expected to know this because you would have checked iStop to see this. That last category is probably a large category of patients for those of us that prescribe. Over the past year, we have worked really closely with the Opioid Stewardship Committee, and we have developed a dashboard, an ambulatory dashboard. This dashboard allows us to look at the number of greater than 90 MME prescriptions we have, prescriptions that are for more than 30 days. We're able to look at areas where there are multiple areas of concern. And one of the new components of this dashboard is we're able to look at what percentage of the categories I just mentioned are we prescribing naloxone for? So what we're able to see is this law just passed, and we have an opportunity here to really improve our naloxone co-prescribing. So right now we're at about a little over 5% of our prescriptions are getting naloxone, and we really would like to change that. So I'd like to just go over with you some strategies on how we can make an impact. Our goal is really to increase that naloxone co-prescribing and get naloxone out into the market so that we can drive down opioid-related overdoses. While we recognize many opioid-related overdoses are not from what we are prescribing, but rather what is available in the community or on the street, getting naloxone education out to patients is still key and important to make sure that they are educated on how to make a difference. So the first thing you need to do is learn how to prescribe naloxone. Talk about educating yourself, and I'll mention some of the training programs. Educate your patients, know about standing orders, and learn the language to eliminate the stigma. So we can prescribe naloxone. There's really two ways we can prescribe naloxone. The first is just the simple, you go into your EMR, you dispense naloxone 4 milligrams intranasal. Make sure you're giving a package that is 2, because you want to make sure that someone has a second one in case the first one doesn't work, or in case that they were there was a slow response from EMS or a delay in calling EMS. The second is there are rescue kits available in the state of New York. They have emergency response cards and instructions, gloves, masks, and the naloxone. They're a little bit more involved. And if you do the training that I'm going to talk about, you will become eligible to actually hand these kits out. We recommend this for people who are prescribing either higher doses of opioids, are doing a lot of pain management, or have a particularly at-risk population to consider getting NALSAT trained, which I'm going to talk about next, and giving out the kits directly. So you can educate yourself. We have a phenomenal 20-minute online training that's called NALSAT. It's for Naloxone Saturation Campaign. It will help you learn how to effectively educate your patients. What do you need to do to prescribe? How do you recognize opioid overdose? How do you administer naloxone? It's incredibly informational. I strongly recommend everyone, whether or not you wanted to dispense kits, go online and take that training. You can also take the training that's the community education first responder training. You can scan the QR code and take you right there. It is really on how to store and safely dispose of opioids, how to use naloxone rescue, how do we do harm reduction, and also it really has some education on fentanyl, which we're seeing more and more in our communities. The synthetic opioid, we're seeing medications that are laced with fentanyl, we're seeing traces of fentanyl in other drugs, so it's critical that we educate. We also have infographics that can help you educate your patients. This infographic will be available on our microsite afterwards on how to recognize the signs of an overdose. Just taking the time to review them with patients and familiarize yourself if it's been a while since you've taken time to do so. Additionally, we have infographics from the Department of Health, this one, and then there's a 2-page one that's a little bit more detailed, which will be available also on the microsite that you can hand out to patients when you give them a naloxone prescription so that they would know how to administer it to someone else and the steps to do it. And we're constructing more educational resources for all of our providers. We're going to have videos where we can talk about the importance of naloxone and how to use naloxone for our patients. Currently, there's a short 30-second video on how to use naloxone that we'll put on the microsite. We'll also have an infographic on why I have received a naloxone co-prescription, explaining the importance to patients and understanding that even though they may have been given a low dose benzodiazepine and an opioid, that there is the need for a naloxone co-prescription. So really making sure that we take the stigma away from being given a naloxone prescription and that patients understand why they're being given one. It's important to know what's available to members of our community and to our patients. So individuals who are at risk themselves Where identify a family member can acquire a naloxone prescription from a standing order at New York State Pharmacy. They do not need a prescription from a physician. They can go to any of the participating 2,000 pharmacies in New York and request a naloxone prescription. Additionally, if you give somebody a naloxone prescription and the copay is burdensome, the NCAP program, the naloxone co-payment assistance program, will take that $40 copay and pay it so that the individual can receive naloxone. And lastly, it's really important that we change our language, that we avoid that judgmental terminology, and that we're supportive and empathetic. We need to drop words like addict and alcoholic and replace that with person with substance use disorder, person with alcohol use disorder. We need to create the new vocabulary and use our vocabulary so that we can have open and honest conversations. We will not make an impact if we can't openly discuss these situations with our patients. Together, we can prioritize educating our patients and our communities on the risk of opioid overdose. If we prescribe naloxone to our patients at higher risk, or those that are even in a high risk age group, we can educate on the use of naloxone so everybody in our communities know how to use them. If we saturate the market with naloxone, we can help change the tide and decrease deaths from opioid overdose. Thank you very much for having me today.
Thanks everyone, particularly Nancy and Yuli, for covering a really tough area. So let's join up for a quick panel discussion. I have a few questions, and anybody else who wants to throw some out, please do. Bruce, first, nursing home vaccination rates. I can understand the community and the politicization, misinformation, fixed beliefs, whatever you want to say about sort of the anti-vaxxers, et cetera. But I wasn't aware that there would be a significant obstacle in nursing homes. Are people in nursing homes saying they don't want to be vaccinated, or are we just not providing the vaccines we should be providing?
No, unfortunately, for the most part, it's the former. And the flu rates are not great either. And, in the past, we've required our nursing home recipients, but more and more people are saying no. I wish it weren't the case, but unfortunately is. It's a very bad time out there for promoting vaccines, and I'm not sure what's going to ultimately change that dynamic.
I think you sort of talked a little bit around this, but so if we have this massive wave, headed in China, what's the chances that may be what might be responsible for again emergence of new variants and spread throughout the rest of the world?
Well, it's certainly, a risk. Most of the new variants, in fairness, have evolved and have come about in immunosuppressed hosts. And I don't really know the population in terms of that population in China, but it's certainly a possibility. More likely than not, unless there's a dramatic change, most of these new variants have not been significantly different from one another in terms of virulence, other than they're all more contagious than the next one, and they continue to march through the population with no end in sight.
I'm sure you saw Tony Fauci's sort of farewell in the New England Journal and his quoting Yogi, right? It's not over till it's over, and of course then he has, and it's never over, and he really goes through a nice chronological description of all the various illnesses that have emerged over his career in medicine, not just his tenure at the NIH. Yuli and Nancy, I think Bruce actually painted a nice picture of being painted into a corner, which is very similar on the opioids thing, right? I mean, Yuli used the term, the pendulum. We have a tough problem, right? I mean, a lot of this was created by the medical industry, whether you want to say just blame pharma or particular individuals, et cetera. But how do we get the public to understand where we now stand?
Yeah, Dr. Banelli, I think that's a very good question. And, to what Dr. Barron had on that slide about using the appropriate language and having the public understand that we understand and we're here with everyone, and understand that substance use disorder, chronic pain, all these all these terms, all these conditions that's been stigmatized for so long are truly disease conditions. And they're something that we're all here to treat together. I think that's very important, and to be able to paint that picture that we're a team, no matter if you're the patient, you're the clinician, is very, very important going forward.
Yeah, that's another question. I mean, opioids been around for a long time, and the majority of at least the peak that you showed on your slides and things is, as I understand it, really a reflection of the introduction into the market of long-acting medications, including long-acting medications that weren't even particularly effective against pain, but caused a significant amount of addiction. With the disappearance of Oxy, et cetera, can we tail this out some other way? And that's, not including all of the illicit and street fentanyl and all that other sort of stuff. But should this start to move back into a manageable number?
Yeah, another great question. I think that, to your point, prescription opiates have tailed off. The fact is that, starting from the 2016 CDC guidelines and with our push towards education, et cetera, it has tailed off. What we need to be careful with at this point is to what you pointed to before, the pendulum swinging back and forth. We want to strike this balance, because what we do not want is to have patients suffer because there's a stigma around it. So I think there's a role for opiates. There's always a role for opiates when it comes to medical treatment. The key is we have to be smart about it. We have to mitigate risk with naloxone. We have to mitigate risk with due diligence, and we have to be compassionate about it.
I mean, I like your point about the language, and I think that will. That's been a long-standing issue. My personal opinion is that that's not really going to come about in any significant way until we have, the other part of the pendulum, where patients actually own their own medical records, and obviously aren't going to want to see the way sometimes they are described inappropriately. Nancy, what about the naloxone piece? And listen, you presented a lot of complicated information. I'd be lying if I said this doesn't seem a little bit too complicated for the average doctor on the street, so to speak. But there might be a way to make sure that the practices themselves have a significant number of experts, champions, call it what you want. And that doesn't necessarily have to be a physician, right? It could be a nurse, an NP, a PA, a particular physician, sort of a go-to person for the practice who can help each of the practices get a handle on this.
And I think what we really do need is education that's broad, that's not just focused on the physician educator, but anyone can educate in the office. And I think we need to make a commitment to getting naloxone prescriptions out to those that are at risk. And it's not just those that are getting an opioid prescription that are at risk. When we look at overdoses and the risk of overdose, 80% of the overdoses happen in our younger population, our 18 to 40-year-olds, and 80% of them are related to fentanyl overdose, or fentanyl being put in drugs. They're buying Adderall or something that is laced with fentanyl. So there really is a tremendous potential impact that we could make by creating programs to educate our community and our patients for naloxone prescribing. So really, that's one of the things we're going to be working on with the opioid stewardship, ambulatory opioid stewardship committee this Q1, is to make sure we have really good resources and educational tools for our practices to implement more broadly.
Yeah, thanks. Yili, let me throw my last point to you, just a particular interest I have, pet peeve, call it what you want. As a pain management person, we need to help everyone understand the role of complementary pain relief meds. And, whether it be NSAIDs, Tylenol, et cetera, that's been somewhat underplayed, I'll call it, and including, I know there's a significant reluctance on the basis of some surgeons to prescribe NSAIDs in the post-op period for concerns about wound healing and other things that these things were generated 30 years ago, has never been borne out in any research that I've ever been able to sort of get into. How do we get that going? Because, the better we can do with pre-op, intra-op, eros, et cetera, the less likely we're going to have to depend on opioids.
I love that. That's a fantastic point. To your point, a lot of this is not necessarily, the reluctance is not necessarily evidence-based and age-old data. So it starts, to your point, Dr. Balnelli, with education. So I really appreciate being here today. The key is to understand the core concept of analgesia is multimodal analgesia, right? The core concept of pain relief is utilizing all the different receptors, not just opioid receptors, all the different receptors, all different medications to strike a balance so that patient's pain is relatively well controlled, where we minimize any of the adverse effects of over-prescribing one type of medication. So to your point, there's a role for NSAIDs, there's a role for neuropathic agents, there's a role for a lot of things that we can do. But the key to your point, again, thank you for the opportunity to be here, is something like this: education, education, education.
All right, and I would also then say, and resource. So you guys are the resource that a lot of people are going to need to turn to help us through this. So, okay, appreciate everybody's input. I'll go quickly through a book recommendation called The Next 100 Years by George Friedman, who's sort of political strategist, been writing for a long time. It was on the New York Times bestseller. It's about 10 plus years old already. Next slide. Just a quick picture of George, who's, very, very well spoken guy. Next. This is obviously, he's, whenever you read about these future things, it's, everybody's got the future marked much sooner than it actually shows up. We've all been to, at least I remember 1964 World's Fair, some of that stuff still isn't here. Next slide. But he goes through some fascinating things. He's really, really well versed in geopolitical areas, and he sort of talks about all these sort of things. Now he's criticized because some of this stuff hasn't happened yet. Although I think people have poo-pooed what's going on in China, but as Bruce said, maybe it's coming. But he talks about how the world will evolve over the next 100 years. What I found most interesting in it was his knowledge about the defense industry and the geopolitics of controlling the planet. And of course, he finishes by talking about, next slide, controlling the planet from space. So kind of an entertaining read. It's always inspiring to sort of see somebody who's got so much of the various politics and history all in one place. So without further ado, we will see everybody soon. Thanks. We need your feedback. We need to hear from you about other topics beyond COVID that you'd like to hear us talk about. And again, thanks to our panelists, and in particular, thanks to everybody behind the scenes who makes this all possible. And if we don't see you soon, have a great holiday, New Year, and we'll be on to our next presentation shortly. Be well, be safe, have a great holiday.